Good morning, everybody. So, yes, I create and implement care pathways in my institution, not only the colorectal, but we are up to about 12 care pathways. But as much as possible, we try to take the elements of ERAS and put them into our enhanced care pathways. So today I'll identify the importance of the team. I think the team is number one for anybody to go forward. I'll describe the important steps before, during, and after the implementation of an enhanced recovery care pathway. I'll identify some strategies in the implementation and the buy-in from frontline staff. I'll explain potential barriers and facilitators in the implementation of an enhanced recovery program. And finally, I'll present some strategies to support and sustain an enhanced recovery after surgery program. This is my team. Now you'll probably say, wow, that's a big team. We didn't start like that. In actual fact, I think if you have your surgeon, your anesthesiologist, and you have your nurse, you're good to go. I pointed out Tara at the bottom. Tara has helped me a lot. When we do at times come into where we can't agree, we lack consensus on certain things, then Tara helps us. She goes to the library, she does a lit search, she comes back with the evidence, and we're often able to move on. And basically, we trust one another. We've been together since 2008. We meet every week, every Friday, 9:30, 10:30, same local. I'm telling you that because it's important. Creates a sense of urgency when you start, keeps up the momentum. And this is a picture, and this is dear Franco, who is always bothering me about data. Right from the start, Franco was always telling me, Debbie, we need data, please give me data. So as you can see from my slide, with all the names that was there, we need to remove the silos. We need to work together. I trust my anesthesiologist, and I trust the surgeon I work with, and I hope they trust me. Distributed leadership. Krem and his colleague confirm what I fundamentally believe in, that not one single person has the ability, resources, or expertise to lead any type of change. The findings demonstrated that the ability to influence and implement change was dispersed across an organization, particularly when interdisciplinary or inter-organizational programs are implemented, which is the case when you have an ERAS program. They report that this type of distributed leadership is spread out vertically and horizontally across levels and is prevalent in healthcare organizations. Hospitals are often very bureaucratic and hierarchical in nature. And it's the staff that makes it happen. We work through that structure and design to make things happen. Regarding organizational change, believe it or not, 70% of change projects fail because of the failure to engage staff at all levels before, during, and after a change, and or to embed the new processes into everyday practices. Gilly and his colleagues looked at behaviors that linked with leadership effectiveness in driving change. Because when you look at an ERAS program, really it's knowledge translation, it's leadership, and it's organizational change. It's not an easy thing to do. In any case, the ability to motivate, communicate, and build team were all predictors of successful implementation of organizational change. Strategies for success, well, I wish I'd be able to tell you, but efficient and generalizable strategies to change organizational culture in healthcare have not been identified, and the best strategies for implementing pathways in hospital settings remain unknown. So I can stand here and I can give you strategies and I can give you clues and I can give you tips, but you will have to go back, and depending on the hospital, the culture, the people, the type of leadership you have, you will have to adapt all this and get creative. So I took a leadership course 2-3 years ago, and I kind of like this book, and I kind of like this rule actually that says that don't waste time and energy with the 5% of people that resist change, trying to get them on board. And we often try to do that. But he says invest your energy with the 95% who get it and move forward. I'd like to share this 3-minute clip from John Kotter. Dr. Kotter is an author and an American professor. He's currently the head of research at Kotter International and teaches at the Harvard Business School. Many of his books that I bought also inspired me, especially the one that's called Leading Change. He outlines 8 practical steps for the process of change management. Now, the clip you're about to see, I sent it to my team. And some of them answered me, "Oh, Debbie, very powerful." Someone answered me, "Oh, I want a t-shirt written, 'Let's get rid of the no-nos.'" And one answered me, "Oh, Debbie, we can't do that. I have a lot of trouble with that." I'm sure you're going to have a reaction. Let's see. Whoa. It worked yesterday. Okay. Got it?
I have a tip for you, and then I'll back up and explain why it's important. In a change process, you will always find around you some people who basically always say, "No, no." And they really strongly mean that. These are the guys that resist to the death. We have a tendency to try to pull them in, to co-opt them into the process, to work away and change their minds. And my tip is forget it. Get them out of the way, no matter who they are in terms of power or relationships to you, because if you let them inside the tent, they will do so much damage that the change will be undermined. Now, let me back up. I have yet to see a major change go on in a company or a government organization where you don't find at all levels some people whose reaction to any new strategy or idea is no, no. Now, some of these people, if they're in powerful positions, will be very upfront about you. Some won't. They'll be very quiet, but that's what they're thinking and that's what they're feeling. And the tendency that I see all too often, and that I think I would have done myself 10 years ago before I saw through studies the problems with this, is to say, well, if only we can spend a little bit more time with George here, we'll win him over. Or, you know, he's important enough that we've got to kind of co-opt him. We'll make him a part of the key team. And if we pull him in, eventually we'll work him down. He'll feel some ownership with this program, and that'll take care of that. My observation has been, if there's strong enough no-nos, it's hopeless. It's absolutely hopeless. And the only alternative you have is to get them out of the way, distract them, keep them out of the way, because the mischief they can do is almost endless. The mischief, for example, in just smiling at you and say, yes, yes, but then going behind because you don't pay attention to them anymore, and doing things that undo changes you've made, talking to groups over here saying, you know, this is a little nuts, and beginning to win them over, of promising to do something, and then, oh gosh, I forgot, or I had this other priority, and it slows you down. The mischief they can create is just about infinite. I think most of us do not like the idea of saying, he's hopeless, we got to get him out of this and keep him out of this somehow. I think most of us don't like that. But I think in cases of significant change, when you've got the no-nos around, that's the only solution. Really, the only solution.
Well, as I was looking through the crowd, I was seeing a lot of smiles. In any case, so we will have resistance when we, at one point, implement. When there's a change, you're bound to have resistance. It's normal. They say that there's 4 most concern why people resist: a desire not to lose something of value, a misunderstanding of the change and its implication, a belief that the change does not make sense for the organization, and a low tolerance for change. However, there's also methods for dealing with resistance to change, and I've used the 3 of them, which is education, communication, which I think I never do enough, participation and involvement, and facilitation and support. And support I also get with other team members. This slide has to do with knowledge transfer and knowledge translation. I think that the ERAS program talks about, yes, we all have the evidence, but up there we have knowledge translation, we have leadership, we have communication skills, we have our culture of our organization. In any case, I wanted to show this to you because I think it talks a lot about knowledge translation. And 30 to 40% of patients do not receive care based on current evidence, and 20 to 25% of care provided is not needed or potentially harmful. And that came from Dr. Estabrook. She visited our hospital a few years ago, and when that slide came, I went, oh, really? It was just an eye-awakening for me. So just wanted to share that with you. It is not an easy thing to put things into practice. Potential barriers to change. It's not coming up. I guess I'll skip it. Let's try it one more time. Okay. So the planning phase. I think the planning phase is very important. You need to know your processes before you do any type of change in your organization. I think it's a good idea also to list all who will be affected by the change. You don't miss anybody. Collect your data. Very important if you have data before you launch your pathway, because after it'll be powerful for the nurses to see the change. I think you need to communicate to frontline staff from the start. They don't necessarily know about ERAS, and they don't necessarily know about a care pathway. So when I started, the first thing I wanted to do was to go on all the wards and talk to them about what was ERAS, what was a care pathway in very general way, and say, and you know what, by the way, in probably next year, this is what's going to come your way. But it was very general, and I did go a second, and I did go a third time to get their feedback on the documents. The last thing I wanted to do was to show up on the floor with the documents already made and present to them. That will not be well received. When you meet with your staff, Let them talk. The laggards, they'll talk. Identify the barriers, they'll identify the barriers for you. So you need to know them so you can either remove them or decrease them. But the laggards are able to name you all the barriers. They'll help you. Schedule regular team meeting creates a sense of urgency and it helps with momentum. And every Wednesday I send a reminder to my team about the topic of the day. Or I cancel. If Dr. Feldman or Dr. Carley can't make it, I usually cancel it. But in general, we have weekly meetings. I wanted to show this to you, and I'm not saying that our drink is a good drink. I'm just going to talk to you about the process it took to implement that in our hospital. It affected anesthesia, it affected surgery, it affected the admitting department, and it affected the patient. We wanted to stop the NPO, and we wanted to have our patients drink up to 2 hours before their surgery. So surgeon, they didn't care really. They didn't mind, as long as their case weren't going to be canceled by anesthesia. So anesthesia took it, part of my team, and they presented to their group. Everybody signed off on it. So far, so good. Then there was the admitting department that called their patients. We have secretaries, the admitting department calls all our patients the night before, and they say, don't forget, you come at 7 o'clock tomorrow morning. Oh, and by the way, stop eating and drinking at midnight. And then the patient would say, but that's not what I was told in pre-op. Don't forget to stop eating and drinking at midnight. And that was the last person that the patient talked to. So after several emails, even a typed script, we're finally, after 2 years, getting better at it. But the patient, the family member. So even though pre-op say it okay, the doctors say it okay, the nurses say okay, pre-admitting say okay, I go and see them just before going for surgery. So, have you drank your juice? Oh, no. Because my wife told me, you misunderstood. That's not how we do it. If you drink, you'll be canceled. So we still have this very much ingrained in people's head because we've been doing it for so many years. So it'll take time to change this, but surely we will do it. Communication. The more information employees receive prior to implementing change, the less likely you are to experience resistance. I always think that I don't communicate enough, but receiving the information in a timely manner helps decrease resistance. Having the opportunity to participate with planning also improves employees' acceptance of change. So again, in the planning phase, somebody has to write the drafts, right? So I write the drafts, and they are drafts. But you have something, get something down on paper so then you can communicate and converse about it and get people around the table to say, I agree with this, I don't agree with that. I think that's one of the first essential steps. You present these, you try to get consensus. I love my job. The only thing I hate about it is shepherd the documents through the approval committees. We have a long chain of approval committees that is too long, according to me. When I submit a document, a care pathway in December 12, and my launch date is 1st of June, In any case, create patient education material. I've talked about that before. Include images, write in plain language. Keep within the health literacy standards, and there's a lot out there about health literacy standard. Communicate the launch date. When I wrote Taylor Introduction and determined strategic planning priorities, is that often on the wards there's a lot of change happening. You want a good time to launch your care pathway, so listen to what's happening on the ward and they'll tell you, okay, this time will be a good time for you to launch. Too much change happening, cognitive overload, so you want to have the proper way, a good reception for your care pathway. Once you implement, well, you keep your fingers crossed everything's going to go well. But if you've covered and did a good planning, I think it's good. But, somebody has to remain as a resource person. That's me in this case, but anybody can do it in your team. Evaluate your patient education material, modify when needed, continue to collect your data. I do spot checking also. Is everybody using the pathway? Who is, who's not, and why? A little bit about sustainability. I believe that visual cues can help in sustainability. I understand not forever, but at the beginning that could help. This is our pictogram, and I took our pictogram and we created 5x7 posters on all the wards of all the care pathways, but this, you're looking at the colorectal now, so that patients, when they walk up and down the hallway, they can see the posters, nurses also. I was very interested when I took this course about organizational change this winter, and I had a definition about sustainability. It is achieved when a process or outcome at a minimum of 1 year later has not returned to its former status. So during that time, organize meeting with all the stakeholders, know what works well, know what doesn't, what are the challenges that you need to improve in your pathway. I organize quarterly meetings with my frontline staff to share the data. Now, when we met, we had a bunch of nurses yesterday, and we met, and definitely some nurses do it much more often than quarterly. Maybe I'll revise that, and maybe I'll be doing it every month. Improve on your data. You're not just collecting data for the fun of it. You want to improve on it. So ask the staff feedback. So what should be evaluated to determine if change has been sustained? Have processes improved? Have the change outcomes become the norm? Will the attitude and surrounding systems altered support the change? Has the change impacted the culture and the values? Change is sustained when behaviors are rooted in the values and beliefs of an organization. Therefore, it becomes institutionalized. With success, you will see improved performance related to the change, and this requires time to make sure that the next generation of stakeholders personifies the behaviors, values, and beliefs that were originally changed. This is simple, easy to do, not costly. Again, a visual cue. This is before we had the ERAS database. We wanted to find a way to give back the data to the, actually this is shared data, not shared date. Give back a way to the floor. So I went with my husband at a hardware store. We got these rigid posters, notebooks. We cut them out, double-sided tape, and voila, every month I used to go back and put new data. I stopped hearing that ERAS did not work because they had it in front of their face. They had the numbers, they had the pie charts. Because before that, ERAS not working, they're not leaving on post-op day 3, they're all here for more than a week, blah, 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 blah. And then, whenever I visited the floor and these were up, then I started to hear, oh yeah, it works. But I think they're all coming back in ER now. So that pushed us to look at our numbers at the ER. So, if you have data, show your data. This is the data that we have from the ERAS databases. As you can see, I'm very, very happy when it comes to the pre-op. We're all blue, that means we're compliant. And then we get a lot of red. But I was happy to hear that our issues that we have in Montreal are a lot of the same issues that we have in other institutions in Europe. So that was comforting for me. Did we resolve anything? Not really. Mobilization and the energy drink is a challenge. And this is usually how we present data and trends. And this is how we usually present data also, quarterly, fiscal year, and so on. But you know what? This is on my to-do and my wish list this year, because this type of data, nurses might struggle to recognize the individual patient impact from clinical performance data accumulated across weeks and months and tracked through abstract metrics, such as rates. But instead, by connecting performance data with the actual number with people icon, leaders can increase frontline nurse interest in the data and create individual investment in improving performance. This particular hospital in Tennessee improved their UTI. I mean, I'm sure they introduced other than just that, but they had very good success rate improvement in their indicator rates. How to get the buy-in from frontline nursing staff? I think communication is key before any change comes their way. I think you need your support from your nursing leadership team on your floor as well. I think it's important to involve them from the start, ask their opinion, feedback. Participation might lead to less resistance. Adapt the evidence to your local setting. Don't be so rigid about it. You know, if you're starting, and then you can modify along the way. Create a vision and share this vision. Whoever's going to present that to them needs people skill, need to have ideas to bring them in the future. My idea was patient education. So I made sure that when I went to see the nurses, I brought my booklets with them to show them how it would be in the next year. The workload issue also. Explain less tube, less drain, mean patient more independent. And they're always invited to our team meetings. Communicate change, explain the reason for the change. Keep it simple, repeat, repeat, and repeat. Be honest, make sure communication is a two-way process, so ask feedback, be consistent. Communicate change, use multiple forums for the message. This I tried about 6 months ago. I had trouble with the residents. We have residents that come and go. We're a teaching hospital. And at times they come in and they don't know which pathway we have. So I decided that I was going to create a website. And it's free. It's called weebly.com. It's not a complicated website there. If I can do it, anybody can. And this is our logo, the Prêt or Sure. We're called the Parcours de Rétablissement Chirurgical du SUM, MUHC Surgery Recovery Program. And I wanted the residents to get on that, and I had to be fast. So what you need to know in 5 minutes or less. And I was telling them what we have as pathways, what's in it for you. Believe it or not, I sent that to Dr. Feldman, and I think Dr. Feldman sent it all to the chief of surgery. And they gave me my statistics, and in 24 hours, I got 600 views. So I tried it, so maybe when I have another change, I'll use it again. I'll finish my presentation by saying that the team plays an important role in the creation, the planning, the implementation, and the sustainability of an enhanced recovery care pathway. The hardest part is holding the change when enthusiasm may die and problems arise. Being successful demands careful attention. Being successful demands careful attention during the beginning, middle, and end. This type of organizational change requires the management support, but at the same time, a willingness to change is required. The quality of the care pathway can only improve if there's a systematic follow-up. You need teamwork, increased communication, and patience. Change takes time. Thank you.